So I might launch into those. Please, if you think of stuff as we're going, use the Q&A and we'll try and respond as we go. But the first question that we got was, is there a chemical process that will break down cholesterol into benign and dispersible parts and so improve heart hydraulics? Now, that had to be asked by someone who's got an interest in hydraulics and hydraulic physics. But I'm going to put that to Dr. Kostner. What's the story with breaking down cholesterol and improving heart hydraulics?
Thank you, Warrick. Good to be part of the program. Thanks for having me tonight. There is a couple of ways we can answer this question. So first of all, the body uses cholesterol for all sorts of functions. It uses cholesterol for organs, for cellular functions, for hormone production, etc. And the body is very well equipped to break down cholesterol if it needs to break it down. For example, HDL, which is often referred to as the good cholesterol, takes cholesterol from peripheral cells and brings it back to the liver, where it's excreted into the bile and then into the feces. So that's one way how the body can break down and clear cholesterol. The other way is by utilizing it for certain cellular functions, whether that's a liver cell, a reproductive cell, a brain cell, and the body can break down cholesterol into smaller particles and utilize it. Now, it's a very interesting question, because what you're probably asking, whoever's asking this question, is why the body doesn't get rid of excess cholesterol that's circulating in the blood, and whether we can have a process that speeds that up. Now, there is various therapies that have been developed but haven't made it to the clinical scenario, where you use, for example, a combination of alcohol and ether to delipidate plasma lipoproteins, which are the carriers of cholesterol, and break it down that way. But because we have very effective drugs without significant side effects, that's not necessary. I hope that answers part of your question.
And look, I'll add to that, because one of the really interesting things about what's going on in the arteries is we know if we lower those cholesterol levels down to, 1.5 millimoles per liter or less, that we see plaque regression. So for those of you listening and whoever answered the question, we actually are able to draw cholesterol out of the plaque in the arteries, which is just, this is information that's really only become available in the last couple of years, and really validates and underlines the importance of us checking levels and meeting those levels for people who are really at high risk.
Exactly, and using therapies, that help us to do that, such as statins, azotrol, PCSK9 inhibitors, etc.
The hydraulics of the heart, I think if you're asking about flow down the particular arteries, that's incredibly complicated. I'm not sure even Karam can answer that, but the hydraulics of the heart will work best in terms of its pumping if the arteries are okay. So as long as we monitor that cholesterol, don't let those arteries block up from cholesterol, then the pumping function of the heart will be maintained. So I hope that answers that. And thanks for asking the question too. Oh, we got Q&As happening as well. Let me just check if there's anything there I need to know. No, no problems. Absolute pleasure to answer. And thanks for asking questions. Look, we've got some other stuff that's been asked. And I think we've got the person who asked them as well. So we've got a question about lipid subfractions and diet. So lipid subfractions is talking about particles and how particles can be of different sizes. There's a question about the possible effects of things like fish oil, olive oil, coconut oil, and animal fats. Would you like to speak to that?
Very happy to give it a go. It's a very smart question, but it would probably take an hour
or more
to properly answer it, but I'll try to make it simple. The one fat that's circulating in our blood that is a risk factor, not as strong as LDL cholesterol, and you've heard that from Warrick many times, but is also a risk factor, is triglycerides. Triglycerides are a storage fat. So for example, if you look at our fat tissue in our tummy, in other areas of the body stores energy in the form of triglycerides. But they unfortunately can also end up in your arteries as part of small, dense LDL particles that have triglycerides attached to them, remnant particles, and other things that I don't want to bore you with. The reason I'm mentioning that is that triglycerides are very easy to influence, and you've heard that in some of Warrick's podcasts, with dietary changes. So if you have high triglycerides, which also can be responsible for pancreatitis, which is an inflammatory condition of the pancreas, you can influence that by decreasing the saturated fat in your diet, by avoiding sugar, by using high-dose omega-3 fatty acids, and several other things. That is basically one fat that's influenced by diet. The real question was about subfractions of LDL. And as Warrick would have mentioned in some of his other discussions with you, they can be very atherogenic. That means they end up in arteries easier than other lipid particles, small dense LDL, for example, but also other lipoproteins. Now, there has been research how you can change these subfractions with diet, but it's not conclusive. Some people say, again, if you avoid butter, cream, saturated fat, you decrease the small dense LDL, but other research has shown that that's only doable to a certain extent. So I think the judgment there is out. But what we do know is that statins, ezetrol, and newer, more expensive therapies lower these subfractions and reduce risk thereby. So that's a quick answer. Again, to reiterate, triglycerides, easy to influence with diet and nutraceuticals such as fish oil. Small dense LDL, lipoprotein A, which is another very atherogenic lipoprotein, and some of the subfractions more difficult to influence because the judgment is out. Is that your take of the literature?
Yeah. Look, if I could add, I get the question about subfractions a fair bit. For those who have not heard the term, we're talking about little particles, little balls, and the best way to imagine these little balls is like a Ferrero Rocher with a couple of layers, and these little Ferrero Rochers swim around in the body and carry cholesterol to where it's needed or where it can be a problem, like in the arteries. It's really important you understand that cholesterol goes around in the body in these little Ferrero Rochers because cholesterol doesn't just sit in the serum because it's a fat. And if we stood around for long enough, it would just float to our brains, which would be a disaster. So it goes in these little particles. We're not going to call them Ferrero Rochers, we're going to call them LDL particles, and they come in different sizes. Now, there's a bit of a beat up by the people who are anti-statin and anti-establishment who will offer this opinion that you can get little small dense LDL particles and these are really bad, and you get big fluffy ones and these are really good. Now, there's no question that diet can influence these. And if you reduce carbohydrate and reduce insulin, you can reduce the small dense ones. The premise being these small dense ones are more likely to get into the arteries. Now, it sounds in theory really, really good. The good thing about the triglycerides and reducing your carbohydrates is you can lower small dense LDL, and you can reduce triglycerides by reducing your carbohydrate consumption anyway. So it's not a bad thing to keep your carbs down.
That's right. And in those people, actually, cholesterol will come down as well in some of these particles, you know.
But back to the particle size story, because I get some people who are really aggressive about the particle size, and they sort of think if they got large, fluffy LDL cholesterol, they won't die because it can't possibly get in the arteries. Well, when you look at it in some detail, the little holes or the fenestra within the lining of the arterial wall that allows cholesterol to move into the wall of the artery where it can cause a problem, if we scale it, these little fenestra, we could say are the size of a basketball, and the large fluffy particles, basketball ring, and the large fluffy particles the size of a basketball. It turns out that the small dense particles are therefore, if you scale it, the size of a volleyball. So if you've got fenestra holes where this cholesterol can go into, and you've got a basketball-sized ring, and you've got a basketball, you can still get that basketball into the ring. You can probably get more in if it's a volleyball, but both can be problematic in the right situation.
Look, that's a very, very detailed and good explanation. Where this all becomes more important, and I know that wasn't the question that was asked, is with HDL particles. Because we know one thing, and you've heard that from Warrick many times probably, that LDL is always bad for your arteries if you have coronary disease or if you have increased cardiovascular risk. So all of these particles are bad, and that's why a total LDL that we measure and that we report to you as our patients is important, and that's where we try to achieve certain targets. So all LDL is basically bad. When it comes to HDL, which is the good cholesterol, particles are even more important because not every HDL is bad and not every HDL is protective. So HDL exists again in different sizes, in different spheres, and some of them are very good at bringing cholesterol back to the liver and excreting it, and some of them are not very good. But having said that, therapies to increase HDL have not shown the same benefit that we have seen with LDL particle reduction.
I'll add in there, the last presentation I went to on HDL cholesterol, they'd identified 250 different particle types, 250 different particle types. So when I have people come into my office who've done all their reading on Google and know all about cholesterol and know why they're not going to take statins because their HDL is okay, honestly, I just can't believe that they think they understand the complexity of this problem. It just blows me away.
Good point. I think we've talked too much about particles.
All right, enough about particles, but there was a question about olive oil, coconut oil, and animal fats and the impact on particles, but probably LDL cholesterol. Do you want to speak to that?
Look, I'm happy to give it a crack. I'm not an expert on diet. I mean, I know a lot about diets that influence cholesterol. But this is an area in cardiology, in preventive cardiology, but also in secondary prevention that is still quite controversial. And I'll tell you why. We know that certain diets are very good for the heart long term. So if you look, for example, at Mediterranean countries, they have a very cardioprotective diet, and we know that it's good for the heart, even though it doesn't reduce cholesterol much. We also know that diets that are very high in fish, omega-3 fatty acids, such as Alaskan Eskimos, etc., have very low rates of cardiovascular disease. But again, these diets do not influence cholesterol very much. There is a diet developed by a Canadian GP called the portfolio diet, which does reduce cholesterol by up to 25-30%, which is like a small statin, and that we often recommend in primary prevention or as an adjunct to exercise and drugs that we prescribe. Now, the question that one of you is asking about, again, subparticles, LDL, coconut oil, and other fats is a difficult one to answer, because a lot of people who have a very high saturated fat diet have that diet to reduce their weight, to feel better from an intestinal point of view, to achieve better glucose control, to reduce blood pressure, and all these things are excellent for the heart. But the same diet that allows us to achieve this, which is more of a very high saturated fat or ketogenic diet, increases cholesterol virtually more than anything that you can do diet-wise. So what you have to do is to balance the positive effect that these diets have against the negative effects. That's the ketogenic diet. But then there's all sorts of other diets which allow you to lose weight. Fasting, for example, various forms of fasting diets. There is diets that decrease satiety. If you have a high intake of protein, for example, not necessarily only saturated fat, nuts, lean meat, fish, your hunger is decreased, and that allows some people to lose weight, which has a beneficial effect on their HDL, on their triglycerides, etc. But again, the studies are limited in all of those areas. And that's what makes this so complicated. So just to reiterate, if you want to lower cholesterol with a diet, a portfolio diet, type diet, which is rich in plant sterols, fiber, soy, nuts, dark chocolate even, is beneficial. If you want to lose weight, if you want to address blood pressure, glucose, prediabetes, other diets are beneficial. If you have a Mediterranean type diet that is very cardioprotective, that's good for your heart, but doesn't affect your cholesterol much, you still have to take your statins, etc., etc.
And so
yes. I'll hand over to you.
And we've talked about this. We talk about this all the time, actually, in our spare time. Nerds on statins and lipids, but one of the really important things is we know there's an equation. If you eat saturated fat, there is an equation that will tell you how much your LDL cholesterol will rise. That it's a double banger name. I can never remember it. Do you remember it?
Yeah, it depends again on
there's an equation?
Hyperlipidemia, but there is an equation, but it's not a simple one. Yeah.
Okay, so there's an equation. So we know saturated fats will push up LDL cholesterol. That's sort of a no-brainer. But the really important thing, which Karam is alluding to, is there isn't a right diet. There is not a perfect diet. You can't have that, because the way to really ask about diets is to turn it around and look at an individual and ask what that individual is trying to achieve from a dietary and health outcome perspective, because there will be people who have terrible coronary arteries and raising their cholesterol. Even if it's a diet that seems okay or compatible with what they're doing, is probably not the right idea. But there are going to be people who've got whistle clean arteries who might be wanting to pursue a diet for a particular reason, which could be high in saturated fat because it's high in protein as well. And this may be quite a reasonable thing for that individual. So it's a really good reminder, I think, that when we try and broad brush, we miss the importance of individual requirements.
Absolutely agree. And unfortunately, not too many dietitians are really in tune with the lipid and cardiovascular risk part of these diets. So you can't just go to a standard dietitian usually and they'll decipher it for you. They're very good for all sorts of other things. Now, just one small addition about the coconut oil. Coconuts are a very wholesome food. There's whole islands that live on coconuts, basically. It is good from an electrolyte point of view. It is good from a hydration point of view. Coconut milk is very nutritious. The meat is nutritious. But I can also tell you that those islands that have moved to, or those cultures that have moved to using coconut fat and coconut oil for their cooking have increased their heart disease risk. And that has been shown in several studies. Doesn't mean that you can't incorporate it in small amounts, but especially coconut oil and coconut fats, if you use them for cooking, like coconut butter, not heart healthy.
Okay. Look, before we go on, we've got another question. Has any research been undertaken to reduce the size of fenestra within arterial walls? Do you want to?
I'll hand over to you for this one.
So Karam doesn't know anything about this, as I don't, which is a good sign.
No, I know a little bit, but I would like to give you the first option.
I have no idea. I wouldn't have thought you could alter it, but
no. It's a good question. The fenestra, and it's a very good analogy that Warrick is using because they're like little holes. So it was perfect what he said about it.
Basketball ring, basketball, volleyball. Correct. It's a great analogy. I can remember.
They are often receptors, so we refer to them as small holes, but they are receptors that dock onto proteins in lipids or other things to take it out of the circulation. And what the question relates to, is there anything that we can do to alter these receptors or holes, whatever you want to call them? And there is a little bit. For example, if you are on statins, atorvastatin, rosuvastatin, and others, you build more receptors on the liver to actually fish out the bad LDL particles. In the arteries, it's more complicated. Certain lipoproteins, which are the lipids that carry cholesterol, or the proteins that carry cholesterol, can dock onto these receptors and others can't. Yeah? And there have been research ideas, why don't we change the receptors so that the bad cholesterol can't dock onto it? But they haven't been successful so far. So it's a good question.
Yeah, great question. I knew nothing about it, so thank you. All right, we're going to crack on. We've still got more questions. So in the line that cholesterol plaque is the sign that there's a fire burning, if you like, there's inflammation. What are the ways to reduce that inflammation? And so to reduce arterial harm. And the question is, are there food type supplements, aspirin, glucosamine, et cetera, we'll come to that. But if we're thinking about plaque, cholesterol plaque within the artery as an inflammatory process as well, what's going on and what can we do about it?
Yeah, also a very topical question, even amongst health professionals. So inflammation is said to influence plaque stability, and you've probably heard that from Warrick a number of times. So you get plaque erosion, you get thrombus formation if you have inflammation, and you get a higher likelihood of an acute coronary syndrome. Now, the first question is, what causes inflammation in the first place? Can be an infection, can be influenza, can be COVID, can be chronic inflammatory conditions such as rheumatoid arthritis, for example, or lupus and other inflammatory conditions. Cigarette smoking also causes inflammation via various mechanisms. But it also has to be said that inflammation alone is often not enough to make plaques unstable. Unless you have a lipid-rich core in these plaques or you have increased cholesterol in your arteries, inflammation alone has other negative effects, but doesn't make plaques rupture. Now, the question is, what can we do to reduce inflammation? First of all, anything that reduces your infection, that reduces cigarette smoking, that treats chronic inflammatory conditions. So if you're on an appropriate arthritis therapy or psoriasis therapy, that will reduce inflammation. And anything that reduces the lipid pool in your arteries to start off with, because then inflammation can't cause as big a problem. So for example, if your LDL comes down very low, and Warrick already mentioned it before, your plaques become more stable. The thin fibrous cap becomes thicker, the lipid pool within your artery is reduced, and that doesn't allow inflammation to cause as much damage. Now, when it comes to food, again, that's a complicated question, but the foods that reduce inflammation are foods that are more natural, not processed. Vegetables, fruit, all the things that Warrick and I don't eat, and I'm just joking. We, of course, eat that as well, but also omega-3 fatty acids. So omega-3 fatty acids, fish oil is one of the most natural anti-inflammatory therapies. And they are the things that I would refer to. And antioxidants, for years, people have said that vitamin E, vitamin C, other antioxidants reduce inflammation. Probably not as important as these investigators initially thought, but as part of a healthy diet, can reduce inflammation as well. Warrick, what's your take on this?
So there's no question that inflammation is important. We have a huge trial called the Jupiter trial, where a guy called what's his name? Ridka.
Yeah, Paul Ridka.
Fantastic guy, a fellow called Paul Ridka, who's pushed the barrier for inflammation. In the Jupiter trial, demonstrated that it clearly has a role. He then went on and did a trial where we used an agent called canakinumab in the Cantos trial. You don't need to remember that. I can barely remember it myself. But it again demonstrated inflammation is central to the process. And now we're seeing trials using an agent that is used for gout to take away the sting of gout and treat inflammation. And it's having a positive effect. So there's no question that inflammation is important in the process. Rather than trying to look at foods and things that might be influential, my simple take on this is coronary artery disease is a very patchy process. So there are focal areas that get hit, if you like. Those focal areas are often on bends or beginnings of arteries and in specific locations. So if you think about skiing, for example, or sport or whatever you're doing, if you bang your leg, you get inflammation. You don't need an external process for inflammation. Inflammation occurs if I whack Karam on the arm and I cause tissue damage. That starts a process of inflammation. And it's really important we get that, because the single biggest driver that I think we can modify superbly well is blood pressure, and we don't do it really well. So my chip at this is blood pressure, and then worry about everything else.
Yeah, and in fact, what we forgot is that exercise also reduces inflammation. Staying fit and healthy and doing exercise
because it lowers your blood pressure,
reduces inflammation. And a glass of red wine, you could argue, also reduces inflammation.
No argument with me. So I don't have any. So that would be my immediate take: is sort out the blood pressure. I think it's super important. I see there's a bit of a thank you there. I'll answer that in a minute, and I'm glad you're finding it interesting. We appreciate the feedback. Very quick comment on whether glucosamine, vitamin K2, or turmeric could be valuable in that space. I'll quickly speak to vitamin K2. We don't know if it's valuable in that space. It clearly has a role. We know if we block vitamin K2 by warfarin, we get more calcification in arteries, but we don't get a negative signal in terms of bad outcomes. Whether vitamin K2 makes a difference in an outcome situation, we don't know. I take a bit of vitamin K2 myself intermittently. When I think about it, I think it's a great story for bone health. So that's the vitamin K response. I'll let Karam speak to glucosamine and turmeric, if you know anything about
glucosamine,
it. And I'll finish on aspirin, and that's the end of that.
Glucosamine, probably not. Glucosamine has been thought to be good for cartilage health in osteoarthritis, chronic arthritic conditions, but recently, unfortunately, the big trials have not supported that. So it doesn't do any harm, but it probably doesn't do much good, certainly not for inflammation. Turmeric, yes. Turmeric and other sort of spices even green tea and coffee do have some anti-inflammatory effects, as does resveratrol, which is one of the main constituents of red grapes and red wine, therefore. So those things do have some anti-inflammatory properties.
So I'll finish off on the aspirin. There's probably some small anti-inflammatory component with the aspirin, but those doses, that very small dose we use for hearts, is probably not an anti-inflammatory dose. You probably need that 600 milligrams a day, because aspirin has a different effect depending on how much you give. So aspirin's role really is at the time when the inflammation leads to a rupture of the plaque, and at that stage you don't want the contents of the blood vessel coming into contact with the contents of the wall of the artery, because that triggers the formation of a blood clot, or a thrombus is the word we use, and that blood clot blocks the artery, and that's a heart attack. So aspirin not being used for an anti-inflammatory role there. And in fact, there's all sorts of interesting information about the role of sort of the non-steroidal anti-inflammatories in cardiovascular disease, and we'd probably be using Celebrex if we were looking at anti-inflammatories long-term. My own personal take on anti-inflammatories, the sort of things you use for osteoarthritis, try and run with Panadol if you can. It's pretty benign. If you do need a non-steroidal anti-inflammatory, use it 3 to 4 days maximum out of a 7-day week, maybe on the days you're busy, the days you're playing bowls, the day the grandkids are coming around, or whatever it might be, so you're not loading the system with some of the negative aspects that those drugs carry.
Excellent. Oily fish is probably the most important nutraceutical, apart from what has been said.
So I think that pretty well covers the questions. And what an absolute pleasure to share an evening with Dr. Kostner, Karam Kostner.
Thanks for having me. Yeah, no, it was fun.
A friend and very highly regarded in Australia and globally. So absolute privilege for me and you guys. So why don't I'll just get you to raise a hand. That can be, or you can even clap, I think. Can you clap? I don't know if you can clap. Turmeric dosage. Good question about, someone has asked about turmeric and the dosage. I think it
depends on which preparation you buy, because some of them are higher concentrated than others. So most pharmacies and health food shops will tell you on their supplements. But if you use it as part of cooking, always a good idea.
All right. So if everyone gives us a wave goodbye, I'm going to wrap it up. It's been really nice for me to share, and I've learned stuff as well. So till next time, take care, and bye for now.